Hi guys. Mm, Very important video that I want to make, and that's on the RCGP SCA examination, the simulated consultation assessment. So if you are going to be sitting this examination, there are a couple of things that you need to be aware of, which I think would actually help make your preparation um, easier and more efficient, and also help improve your performance in the exam itself. So I'm the tech doctor, no cybots, and let's proceed. So while you're still, preparing for your exam, of course, it's very common to have this feeling of um, a bit confused as to what exactly you should be doing to prepare for this examination. There's a common myth that the SCA is not all about knowledge, that you've demonstrated your knowledge in the AKT. Well, I want to debunk that myth. The SCA is very much about knowledge. And what do I mean? You need knowledge to confidently navigate the SCA. The SCA is a highly standard examination. Of course, it resembles a normal consultation, but when you experience the exam, you realize that the case is actually well formulated to be standard and have a moderate to high level of complexity. So moderate to high level of complexity, not a mild complexity. The barest minimum is a moderate level of complexity in the SCA. So it's a very well designed and well formulated examination to assess ST3 GP trainees who will be emerging as newly qualified general practitioners, family physicians. So updating your knowledge is paramount. You need to revise using the mini-CEX list of clinical topics. Make sure you can manage every case on that list. So I'll get to show you exactly what I mean by this mini-CEX list of health topics. From my experience, most of the cases are actually extracted from that list. Because the NICE guideline, which is like the Bible of UK medical practice, is expected to contain everything, isn't it? So it's just common sense that actually most of the cases, if not all, would be on the mini-CEX list of health topics. The most important way to practice for the SCA is actually what you do normally, which is consulting. So becoming more aware of the things you're telling patients, or how you're explaining diagnosis, or why you're making that diagnosis, and how you're engaging patients in discussing the management. Bear in mind that in the SCA, there's no physical examination, but in real life, you could, in real life, in most cases, you would be examining your patients, especially when they present to you face to face. So try to apply the important macro and micro skills during your actual consultations with your real patients, just so it becomes second nature, because the SCA, to be honest, will feel like a real clinic, feel like a clinic, it feel like you're seeing 12 patients, and that's exactly how we should feel. I also engaged in peer group studies for about 3 to 4 months. Excellent colleagues, we're 5 in the group, amazing people, amazing colleagues. We worked on one another, we ticked one another's consultations. It was not the best acting, because obviously we are doctors and we know exactly what we should be saying. And we're a bit biased in our acting, but we tried. Some of us became, the next Nollywood actors. So I want to use this opportunity to really thank my study group, partners, excellent doctors, and amazing people. So peer study group is very important, just so you have the opportunity of critiquing one another and learning from one another. Of course, you have to be nice in your feedbacks, but you don't have to hold back. I'll advise, don't hold back any relevant correction or critique that you think will really help your colleague to become better. It might make them feel a bit reused in terms of their confidence, but when they think about what you've told them, eventually they apply some of those things. It might help them actually correct some of the mistakes they're making and eventually become better doctors and obviously perform better in the SCA. You need to be ready to encounter cases from all the RCGP clinical experience groups. And what does that mean? Everything. Just be ready to see pediatric patients. Is it autism? A mom who's worried about a child who will be autistic or has ADHD, or she's worried about a child's, learning, Down syndrome or something. We're ready to see people who are presenting with STIs, menopause, male infertility, female infertility, or a couple. We're ready to see people who are presenting with acute, urgent and unscheduled care concerns, chest pain, difficulty in breathing, severe hypercalcemia, severe hyperkalemia, severe hypocalcemia and hypokalemia, like, those kind of metabolic and severe diabetic complications, DKA and the likes. You're ready to manage metabolic and, and other acute conditions. Health promotion. So the moment a patient tells you, in this situation, the professional actor tells you anything that has to do with sexual health. Oh, doctor, I'm worried about Kaposi sarcoma. I'm worried about I've heard about pneumocystis carinii. I'm worried about HIV. I'm worried about, gonorrhea, chlamydia. Whatever, something STI related, you need to be thinking health promotion, and your data gathering section. Even if you've got to management and you've just remembered, oh, I've not really explored this patient's sexual history very important. Well, so here, while we're still here, I'd like to ask you a few more questions about sexual habits, if that's all right. And then you go into exploring the kind of sex as the protected, who are the partners, multiple partners, and things like that. Expect cases. Cases could come under someone who is palliative, somewhat metastatic, malignancy, somewhat advanced end-stage COPD, and, advanced dementia, things like that. You need to be ready to have a conversation with the next of kin, or maybe a social worker, or a carer in a nursing home or residential home, something like that could come out, You need to be ready to manage a patient who is presenting with a long-term condition. It could be an acute or chronic, so it could be someone who has COPD and is having an acute, either infective or non-infective, exacerbation, or it could just be a COPD review, or it could be asthma review, or someone who is asthmatic and having poor control, a review. Obviously, it could be diabetic review, hypertensive review. You're ready to manage those kind of cases. And then all other, clinical experience groups as well. You need to look into all of them. You have to prepare to encounter some cases that are not very common, but obviously, a doctor, a primary care physician, anything can come your way. Even if a patient's head, the patient tells you that their head, they feel like their head is in their tummy, they can come, anything can come to you in primary care. So some cases which may not, the fact that you've not seen a case during your 3 years of primary care doesn't mean it's not going to come out in the exam. That's all I'm trying to say. I wouldn't obviously be mentioning cases specifically that I encountered in my own exam, which I felt were not very common, but thankfully I was able to use residual knowledge to navigate some of those cases. And somehow I also stumbled upon a few and revised a few of them as well. But you need to be open-minded and go through the nice CKS health topic lists, which is the A to Z. Go through all of them and ask yourself, can I manage each of them? Now, on the exam day, what exactly should you be looking out for? You need to relax. You need to feel confident. You need to realize that it's actually an exam you can't do without. You must do this exam for you to emerge as a GP. Okay, so you can't become a GP without passing your clinical exam, in this case, the SCA. So it's something that must be done. It's not something you can run away from. If you run away from it, you can't become a GP. So you must do it. So accept that reality that it is something that must be done. It's like a ritual that you must go through to become a GP. Our advice, don't see this as an exam. Obviously, it's an exam, it's an assessment, and it's very important. It's a step you must cross. It's a hurdle you must cross to become a GP. But psych yourself up. Trick your brain into just looking at it as a normal consultation, which is what you should have been doing from the beginning of your ST3 consulting. So see it as a normal consultation. You're going there to find out what problems this patient has. Also tell yourself, no matter the problem this patient has under the sun, no matter what this patient comes with, I'm going to be able to help them. Even if I'm not so certain about how it's managed, we can work things out. As long as you're safe, as long as you're reasonable in your management, you should be fine, hopefully, fingers crossed. Obviously, that will still depend on how well other candidates perform in that situation. So if other candidates are well knowledgeable on that situation and handle it much better than you, and obviously the pass mark could be higher and then you might be disadvantaged. Or the other candidates also find that case equally challenging, then all of you might, balance out. You know what I mean? Don't want to make it look like you're competing with your colleagues, but from what the RCGP is describing, it looks like everybody cannot pass because they said general performance will determine the pass marks. So I'm wondering, what if everyone performs well? Does it mean everyone can pass or must someone fail? We don't know that information. Stay calm. Panicking would only make things worse. Anxiety is a brain blocker. You don't want your brain to be blocked. You want your brain to be open. Believe you've already been successful. You're a good doctor. Believe in yourself. Don't be scared. Believe you have all it takes to provide that necessary safe care for the patient. Remember the 3 domains that you have to satisfy: data gathering and diagnosis, management, relating with others. Remember that diagnosis is part of the first domain, okay, and management. So essentially the exam is divided into 2 parts: data gathering and diagnosis, which is one arm; management, which is the second arm. Relating with others is just something that happens throughout the consultation from the beginning to the end. So it's not really a standalone domain. It's just how you approach your consultation, how you gather your data, how you explain your diagnosis, how you manage the patient. Everything, the approach you take is what relating to others or interpersonal skills entails. Don't forget to gather data in cases where you're already provided with some investigation results. So you might find, because there's no physical examination in the SCA, you might be encountering the fact that a lot of cases might come with investigation results or letters from specialists or things like that, because they don't want you to examine, so they'll provide as much information as you would need to manage that patient. And most of those information will come by way of maybe your colleague has seen this patient before, your colleague has already examined this patient, or someone examined the patient in hospital recently, or your colleague requested some investigations and results are available. So they'll provide you with as much information as you need. So you don't need to tell all your patients, I'd like to bring you in and examine you before I can make a decision. You know what I mean? Don't forget to mention your diagnosis because it's part of your first domain. So you need to tell the patient, from everything you've said, I think you likely have this, or I'm not very sure what's going on, but I'm thinking it could be this, it could as well be this. If you're not sure, you give differential, it could be this, it could be that. But I think it's more likely to be this, okay? And you explain why you think, because you've mentioned this, and for everything you've said, it's really typical, or it gives me strong impression that we're having an acute, or a chest infection from COPD or whatever. Explaining those things. So give your diagnosis or what you suspect may be causing the symptoms or the problems. Always check the patient's knowledge. So I think you're having Reynolds phenomenon. I think you're having, doubts. Is this something you're familiar with? Is this something you've heard about? How much do you know about this? Before you then explain, give them further information. Don't forget about the end of your examination, of your assessment, rather, how you close your consultation. Always remember safety net. The barest minimum safety net is, if you don't get better, let me know. That's the barest minimum. If things don't get better, if things don't settle, kindly let me know. That's the barest minimum. If it's something that you think you need strict, safety netting, like acquiring back pain, you begin to give them, or chest pain, you begin to give them very strict safety net instruction. But if it's something that is not a high risk, then you could just use that umbrella term. If this doesn't settle, kindly let me know, and they'll probably need to bring you in and reassess things. If you think there's a need for a follow-up, you need to give a follow-up. Okay, 2 weeks, could be a month, could be 3 months. depending on how quickly you need to be assessing that patient. Another thing I found myself doing was as much as possible, I was trying to reiterate or summarize the plan. So after explaining a plan, maybe I've said, like, okay, yeah, I've said a lot, and just to summarize everything I've said, this is or list out, what I have said in terms of my plan. Don't forget health promotion. I've already mentioned this earlier in the video. Health promotion is very important. So if you mentions anything else SCI related, you have to explore their sexual history, and then ask yourself, should I actually be discussing health promotion, signposting them to the sexual health clinic, and encouraging them to practice safe sex, use contraception and things like that. Health promotion, of course, can be smoking cessation, could be lifestyle management, could be occupational changes or could be occupational modifications. So we're thinking about these things, asking yourself, should I be thinking about health promotion in this case? The RCGP might choose to make most of the scenarios to be non-smoking or smoking, depending on what they want to achieve. In that particular case, they will tell you, if they don't want you to focus on smoking cessation as part of your management, they'll just tell you the patient is a non-smoker, the patient is an ex-smoker or something. They want you to bring in smoking cessation into that management, and we'll just probably tell a patient smokes 20 a day or something like that. So pay attention to those things. Don't forget to explore the patient's eyes, ideas, concerns, expectations, especially their concerns and expectations, and even their ideas, and the impact and their social situation. Is this patient living alone? Have they got support? It helps you manage the patient. It helps you really know whether you can safely manage his condition at home, or whether you need to admit this patient. We need to probably be thinking about respite care, for instance. We need to be arranging carers and things like that. So because this is an exam for family medicine for primary care. It's not secondary care. So you need to demonstrate that you understand that there's an option of managing patients at home if deemed safe. You need to establish that safety or not. No matter how prepared you are, no matter how much you psych your brain and psych yourself into thinking it's just a consultation and not an exam, you can't lie to yourself. You still know it's an exam. So you might be a bit nervous, especially in the first 1, 2, or 3 cases, before your nerves begin to settle. And that's completely normal. And what that means is that you might naturally not say everything you would have wished to say, might not have gathered all the data you'd have wished to gather. There are things you remember after the exam. As days go by before your result comes, and you will begin to panic and be like, oh, I hope this will not severely affect my chances of passing. That's completely normal. Okay, do the exam, do your best, and just hope for the best outcome at the end of the day. Remember, you need to treat the SCA as a clinic where you have 12 professional actors or role players who you should be seeing as actual patients, because that's the only way you can actually manage them properly, by seeing them as actual patients that you need to explore why they've come, and you need to be discussing how you can help them. Another thing that can help you psych yourself up is just imagine that whoever is going to mark that exam is a potential employer. So you're obviously finishing your GP training, you're going to be looking for a job, and you should be asking yourself, okay, this person who's going to mark my station 1 or my station 2 or my station 10, let's assume they're looking for a GP to replace someone who has just left. Would they be happy to want to employ me based on the performance they can see? So look at it like a recruitment exercise as well. Try to impress the examiner, try to show the examiner that you are a qualified GP. When I talked about the mini-CEX A to Z health topics, this is exactly what I was talking about. So you log on to your mini-CEX, you see health topics A to Z. Looking at the screen, you can see abdominal aortic aneurysm screening. So you need to know about the screening of AAA, because it could come as a patient, maybe they might provide the results, investigation result that patient has, an ultrasound scan that confirms AAA. I need to discuss that with the patient. Achilles tendinopathy. It could be maybe a case of ankylosing spondylitis, with Achilles tendinopathy, or it could be traumatic. So you don't know, just need for vulgaris, alopecia areata. It could be a patient with alopecia areata. How do you manage alopecia areata? Do you know? Amenorrhea, B12. Okay, so anything, it's a list of A to Z. If you look at it, it's A to Z. So many topics there. Believe you me, most of the cases will be on these A to Z. Of course, they should be, because this is a nice guideline, right? mini-CEX. Make sure you have a clear understanding of the assessments of those cases. Another resource I used was my website. So this website I compiled towards the beginning of my ST3 website that really helped me, navigate through consultations very quickly and effectively, because I put together a lot of resources that I commonly reference. So the BNF, Northern A-level formulary, GP notebook, mini-CEX, even my 14 fish link, and there's some useful links, leaflets, then links there, Dynamite, BMJ best practice. So, I added, and then I screen shots and added a lot of, algorithms and guidelines. You can see the top one menopause, so you can always go through, you can go through the link, I'll add in the description. You can access this website, it can help you. Your duty is just to always make sure that you're updating some of these. I might not be, updating some of these stuffs, guidelines immediately, and guidelines change so well. That's why I put a disclaimer, so you need to always make sure. But basic medical information doesn't change every day. You know what I mean? Yeah, even books that are written in 1915 medicine are still relevant. Most of the 80% of the information, 85% of the information in books that were written in 1615 medicine are still relevant till today. So information are just slightly tweaked. Maybe first line, second line, what's the core medical information remains the same. So don't be scared. You can always double check things to know whether things have changed. There's been a recent update, okay? But the information remains relevant. And I want to say best wishes to all of us, because I'm still waiting for my results. My results should be out in 2 weeks' time. Really hopeful. So this best wishes is to you and also to myself. All the best. May it favor us and may it go well with us. Cheers, guys.